Hello and welcome to or welcome back to Sharp Scratch. This is a podcast brought to you by the BMJ, where resident doctors, medical students and expert guests come together to discuss the things that you need to know to be a good doctor, but you might not get taught at medical school. I'm your host, Zaynah Khan. I'm a medical student in London and this year running BMJ student as the editorial scholar here. Happy New Year, because this is first episode in 2026, and welcome back to an exciting episode. This is part 2 from one we had during our Christmas episode, which is exploring all things medical language. And we are joined by our very special guests who are here with us in the last episode. First is our panelist, Nikki. Would you like to introduce yourself?
Thanks for having me, Zaynah. My name's Nikki. I'm an FY2 Doctor in Surrey, and I'm a previous editorial scholar. So lots of happy memories with Sharp Scratch. So always a pleasure to be back.
And excitingly, we also have our expert guest, Matt Morgan. Could you tell us a bit about yourself?
Yeah, hi everyone. My name is Matt Morgan. There's two bits of my life. I'm a full-time NHS consultant working in intensive care in Cardiff. And the other bit of my life all is about public engagement and writing. Having written some books, done some advisory stuff for TV and theatre and radio, and a columnist for the BMJ.
Yay! Well, thank you both for coming back, and I'm really excited for this episode. So I guess in terms of part 1, if you haven't heard, which you should go and listen to, we go through the idea of language and whether it has any limits in trying to capture our clinical experiences and how we might shape our own word to kind of try to describe those really niche experiences that we do have. And Matt takes us through words that he's created to try and capture those emotions or sensory experiences that we don't quite have the words for. In this episode instead, I thought we could discuss a bit more like the other way around. Like day in, day out, you're experiencing so much of medicine, you almost learn a new language when you enter. And how does that work when you're going back to your personal life? Does it seep through, or how do you kind of maintain that balance? Thankfully, we have Nikki here today, who has a very exciting idea or project going on related to this. So I thought Nikki could tell us a bit more about that.
So I've also written a piece for the BMJ Christmas issue, which is, as Zaynah said, a bit like a reverse of the piece that Matt spoke about in the last episode. So the idea kind of stemmed from every time I would catch either myself, my friends from med school, my work friends, using a piece of like medical jargon, work terminology, completely out of context in our kind of home and personal lives, almost like a joke or almost as if we've kind of created our own slang. And I'd started to write this list down in my notes app on my phone just because it was quite funny, these things I'd collected. And it started to feel like something that might be a BMJ Christmas piece. But it's been really interesting to kind of collect and formulate. Similarly to Matt, I've been asking lots of people to contribute to it so it doesn't just become a personal collection of weird things I say. But it's really had me thinking about the kind of migration of language and how we really adapt terms that kind of originate from one context and use them somewhere else because they perhaps better capture the intended meaning. And it's not unique to medicine. I think we already do this in loads of different ways. So there's already kind of different words from different languages that we use in English day to day. So phrases like déjà vu, we can say, I feel like I've seen that before, but it doesn't quite capture that same feeling. Or even kind of corporate jargon that you might recognize, like bandwidth and circling back and low-hanging fruit, that becomes quite normalized day-to-day terms. So I've put this piece together, which is like a list of the clinical lexicon that's migrated into medical slang.
Which is so exciting, because I remember kind of going into medical school when I was like joining, my teachers and everyone were like, make sure you know this is what you want to do, because this isn't a job, it's a calling, like this is who you are. And I think that's not something that's necessarily said when you're applying for other subjects at university. So there is this idea of kind of medicine imposing on like who you are and in your life. So I think the idea of it seeping into like how you speak with your friends when you're like going out or something is really interesting. Matt, I was wondering if you had any kind of similar experiences or thoughts.
Yeah, well, it just struck me how right Nikki is. That's a beautiful way to describe it. And I think, you forget medicine is actually a humanities degree as much as a science degree. In fact, it's said Yeah, it is. And even if you want it to be or don't want it to be, it's said medicine is the most humane of the sciences, the most scientific of the humanities. And it's easy to say that in a throwaway way. But actually, now listening to Nikki speak, you are going to learn a language when you join medical school. That is what you're doing. And we don't even notice it. I'm in Wales at the minute. I'm Welsh. I was born here, but I don't speak Welsh. And that's kind of been shameful for me. So the last 12 months, I've been trying to learn my own native language. It's really difficult, unless you're using it every day and talking to others. And yet in medicine, you're immersed in that every day. So of course it seeps, and I haven't thought about it. Nikki, I'd love some examples if you can tell us what are the top three in your list.
So the one that came up the most often when I asked people was using query. So for anyone listening, if you haven't come across using query, and it's normally in written form, it's different from asking a question. I need to be really clear about that, because it's not as open-ended. It's almost like a suggestion, and you're open to it being put down. So I'll read the definition I've put for it. So query, found in written form as a question mark preceding a word. Examples include query coffee or query lunch, which is what I'm texting my friends on other boards throughout the day, suggesting you're ready for lunch if the other party is. So I'll send that message like, I'm at a point where I could go for lunch, but if you're not yet ready, we could come back to it. So it's suggestive, like yes, unless proven otherwise, which differs from asking a question as it's suggesting the likely outcome.
Love that. Yeah, absolutely love that. And of course, it's not just about language, it's about things like human factors, that way out if you don't want to. And in fact, I was I was complaining about something very menial a couple of weeks ago in a leisure centre, that the showers were cold and this, that and the other. And I found myself using graded assertiveness, which is what I use at the bedside in intensive care, where the first thing you say is very polite, please can you get me the adrenaline, please? And then if it doesn't happen quick enough, it's please get the adrenaline. And then the final word is adrenaline now. And I was in a completely non-medical scenario, naturally just taking on this weird role that we perform in work, and language does that.
This is something that I was really thinking about while writing the piece, and I don't think it ended up making its way into the final version, but kind of about how I was almost sat there wondering, can you recognise doctors in the wild, like on the streets and things, when they're not talking about anything medical at all, just based on how they're phrasing things, their approach to things? And I think to an extent you can. And I think I was telling Zaynah the other week that I had an experience where I went on holiday with one of my friends from medical school, and these two girls who were probably about 5 to 10 years older than us sat down next to us on the train in Italy. And it was just the way that they kind of spoke to us politely, asking us to move our bags off the seats so they could sit, but with such assertiveness that I just knew that they were my reg. And I was like, that's my reg, she's told me what to do. And I texted my friend saying, I think they're doctors. And she was like, they haven't said anything, how would you know? But half an hour later, they started to talk about GP training and things like that. And it was like, I knew. But they didn't mention anything medical at first. So it's interesting the examples that you gave there, that whether you can spot those kind of patterns in how we phrase things, or that kind of approach, I guess.
Yeah, I love that. And as you said, it's happened in other realms, but often it's business, for example, that take on skilled job languages. So you mentioned about circling back and low-hanging fruit, and things like doing a deep dive. Well, you're not a scuba diver, so you don't need to do a deep dive, or reaching out. You should only reach out if you're an actual member of the Four Tops group that sang the song Reaching Out, for example. But in medicine, it's the opposite way around. So we do use those words in medicine, which are important to communicate, but they seep into our lives. I love that.
Yeah, some of my other kind of favourite examples, if you are checking to see where your phone is, you might palpate your pocket to check that you've got it with you, using words like acute and chronic, or medial and lateral, instead of kind of more simple alternatives. And then one that I've noticed a lot is people referring to themselves with like a scoring system, like if they're very like tired, unwell, using a GCS, a news score, or even a clinical frailty score. A lot of my friends love CFS4 as when they're vulnerable, even if they mean like emotionally vulnerable. Things that I've noticed thrown out a lot, often starting kind of as a joke, and I think that's why I kind of referred to it as almost taking on a place as slang for us. But it's this list of kind of already familiar vocabulary that we have. So it's very easy for us to draw on these terms and use them in other contexts. Some of my other favourites are Meals on Wheels for getting a takeaway, or referring to my flatmate as my live-in carer. Also triaging emails. And the one that I think properly inspired this whole thing was when me and my friends take a piece of information, a piece of gossip, or ask for advice to our group chat, we take it to the MDT because everyone has varying levels of experience and expertise in different things. So that's when we like take things back to our other circle of friends, that we've taken it to the MDT.
And now that you've written this and you notice this, do you do that more, or do you notice yourself doing it and purposely kind of de-doctor yourself and use normal English words? How has that changed you?
I've definitely been using it more, I think, because they've been going around in my head for weeks now. But interestingly, almost everyone I asked initially said, I don't really, maybe I'll say query sometimes, but like, I don't think, kind of very assured by their separation of their personal and professional lives. And almost without fail, a couple of days later, weeks later, I would get a text saying, I've just said. So one that I had that really made me laugh was weeks after having this conversation with a group of my friends, one of the boys that we were with messaged me saying, I just referred to a situation as being completely benign.
Yeah, I guess maybe in a way, it's just life coming full circle. So, we know lots of medicine is based on Latin and Greek, and, the muscle in your leg is sartorius, which means sower, and that's because they needed to cross their legs when they were sewing. So actually, these words started as normal words. They then were kind of emigrated into medicine as a way of doctors and others really, excluding patients or forming a language to make a specialism, chiseling out a niche for themselves. And actually what you're now describing is just the return to sender, the regress to mean of language back to where it belongs. And hopefully, in medicine going forward, where we need to be companions with patients and families and not exclude them, we can start using words which are recognizable. It blew my mind a few years ago. I was writing patient information leaflets for a research study, and of course this is being read by patients and families. The average reading age in the UK, depending on which area, is, it could be as low as 9 to 10, 9, 10, 11. So when we are designing information leaflets and talking to patients and others, of course you need to adapt to them, and averages mean nothing, but that's the kind of level that we need to think about in order to communicate effectively.
And I was thinking about, in terms of, Matt, what you're saying, where things are becoming full circle. Some of these things almost have like breached containment, I guess. Like, in terms of your friend saying like describing a situation as benign, I've almost heard the opposite. Like I'll be reading a book or watching a normal movie and like a non-medic would be describing a bad situation as cancerous. So it's almost like that medical jargon is like sneaking into like normal mundane life for non-medics too, which is interesting.
Yeah, I guess it's about exposure and things in a way as well. And I was just thinking there about how I think in the previous episode we were talking a little bit about patients having access to their notes and things now. And I wonder if some of the shorthand and abbreviations and things will start to be more widely recognised, things like BD, NAD, all the other kind of acronyms that we use.
Sometimes, sorry, this isn't random, but I have a friend who's like obsessed with Grey's Anatomy. Like she rewatches it 4 times a year. Nothing to do with medicine, like in her life. But sometimes she says these words, and I'm like, why do you know what a tracheostomy is? So it's like, yeah, maybe these things are becoming more like I guess, publicly available. So less of that kind of exclusionary use of language for specialisms. So it kind of becomes more universally acknowledged.
Yeah, I guess language is always influenced by our kind of cultural environment and exposure to different things. And that's kind of how slang develops in the first place, whether that comes from kind of generational slang or whether it's cultural. I guess that the rapid turnover of that at the moment is probably because of the level of exposure that we have. So there's phrases that are become really popular and then suddenly something else is more popular the week after. And I guess that's to do with the level of exposure.
I think that kind of links quite well to the second section of this episode, is like thinking about where jargon comes from. Like all these kind of medical terms that when we start medical school, we're like, oh, we're learning this new language. Where did these words come from? And who comes up with them, and how do they stick?
Yeah, well, I guess there's perhaps three main ways. I suppose it originally comes from normal life, so from Greek and Latin, and I mentioned sartorius and lots of other things before, and they are transmutated to make a professionalism or to make a new language. But also sometimes words come from super interesting places as well. Often one of my ward round questions relates to warfarin, for example. Why is warfarin called warfarin? And it relates to the Wisconsin Academic Research Foundation, which first discovered some rotten hay, which caused bleeding in cows where they actually were. So I think that the nice thing about looking into language and lexicon and where words come from, the etymology of words, which in itself is a word, the etymology of words, it also helps us understand. It helps us be motivated to learn. It teaches us a bit of history. It teaches us the path to things. And so I think having curiosity about words in medicine is actually helpful for understanding too.
Definitely. I had, as a part of BMJ Student, we get pitches for people like sending in articles that they want to publish. I recently was reading a pitch that was quite interesting, looking at like the etymology behind anatomical words, where they come from, what it means, and how it affects things. So I don't know, that was just interesting. It reminded me of that.
I think that would be a really useful piece in terms of, I'd have found that really useful at medical school. I think it would have helped me remember the meanings of words much better. Because actually when I was writing the piece, I looked into, I'd heard somewhere before, actually might have been on a Sharp Scratch episode, that first year medical students learn more new words than first year modern language students at university. And I looked into it, and I found estimations that medical students learn 9,000 new words during their first year and about 55,000 words over the course of their medical degree.
That's a lot of words.
Which is a lot. I don't think, I was like, do I know 55,000 words?
And of course, along with those benefits, like always, comes risks. So, there's risks in alienating patients' families if we are using fancy words with knowing the average reading age is low. But there's also dangers in us using words to protect ourselves. So I'm involved in a project at the minute about a glossary of terms for breaking bad news. So breaking bad news is something I'm really interested in, is something I think is really important, not just in medicine, but in all aspects of life. And yet often it's done very badly. And sometimes that's to protect ourselves. The classic is, if somebody has died, you need to say the D word. You need to say died. They have died. What you shouldn't be saying are other words around that. So they've gone to a better place, because then patients think, well, where's that? Is it Ward 6? Or they've moved on. You need to say the D word. So I think words are fascinating, not only for patients' families, but how it affects us as doctors, and is it a way of protecting ourselves too?
I suppose that all kind of comes back to the context in which we use those words, right? Which is sort of what my piece began being about, because I think you're right, there's a time and place for jargon or for acronyms if they capture something quicker, better, for more efficiency, when you've got a high volume workload and need to prioritise communicating amongst other colleagues. But I went to Manchester Medical School and they were very hot on comms skills and OSCEs and stuff that examines that from very early on. If you were in a Breaking Bad news station and you didn't say the word died, or if you had to talk about a new cancer diagnosis and you didn't say the word cancer, you would fail the station if they were really clear about that. Or if you had to explain a new medication, as soon as you dropped in any kind of jargon, you would be marked down for it. And we all didn't realise the number of words that were so normalised to us that were actually jargon and might alienate a patient or family. So I think that glossary would be really interesting, because you're right, it's often so tempting to pick a slightly softer sounding phrasing because you feel as though you're being kinder to both yourself and the receiving party. But actually, when you go back to thinking about the purpose of what you're trying to communicate, when there's already so much else going on, so much other uncertainty, in that moment, the kindest thing is to provide clarity and simplicity and to remove as much of the doubt as possible, I guess, because there's already so much more of that circling around for them.
And I think also, like, from our perspective, I can't remember what it's called, like the Feynman technique or something in terms of studying. Like, you only actually really know a topic if you're able to explain it to like an 8-year-old. If you're in a consultation and you're using all these fancy words to explain it to the patient and they don't get it, I question whether you fully understood it either, because if you can't explain it to them in a simple way, maybe you need to go and look at that a bit. I don't know if that's fair.
Yeah, no, are you reciting a list of things that you've memorized, or do you understand the core of it? It reminds me of, I used to say this a lot when I was working on BMJ Student and talking to different student authors. I think we are all under the impression that academic writing, particularly kind of scientific academic writing, needs to be complicated and complex and difficult to read or understand, and that's how you sound clever. But I would always go back to authors and say the best writers are the ones that, and I guess also the best communicators in spoken form as well, that take a complex topic and make it feel simple. And that's when someone's done their job at communicating something brilliantly.
Yeah, I think simplicity is such an important thing. I think, in fact, isn't the shortest story ever told, I think, is just 6 words, which is for sale, baby shoes, never worn. And, those 6 words just speak so much complexity, actually. And I think, some practical, real-world ways that people who are listening can do that. And this isn't always possible, and it's not easy, but certainly when I write about patients in hospital notes or try to summarize things, I go back to narrative. So I love data. I'm a scientist. I love that side of things. But your job as a doctor isn't just to transcribe a CRP from the electronic blood results into the notes. That's not a thing. That's not a job. It's not helpful. Your job is to contextualize that. And how better to contextualize complexity with narrative. So, rather than say CRP 310, white cells 25, strep pneumonia in sputum, you say, this is a patient I'm worried is sick enough to die, which is a phrase from Catherine Mannix, the palliative care physician, which is brilliant. I'm very worried about them. I think they have severe infection from community-acquired pneumonia, and I'm worried they may deteriorate. That says so much more than a load of data. And actually, although it sounds time-consuming, it's actually not. Much like that shorter story, 6 words, narrative sometimes tells you so much more than a page full of data.
Definitely. And I guess the time that it would take to decode the data and then clarify things is saved if you just kind of put it simply in the first place.
And again, some other ways and hacks that people can think about that, especially if you're worried it's time consuming, you can develop your own stock phrases that you like. And stock phrases doesn't mean that they are just blanket phrases for everybody. They need to be contextualized. But the time to think about complexity of language isn't at 3 a.m. when you're trying to make a best interest decision about a patient. That's not the time you need to be at your very best writing. So think of these things beforehand. So, for example, if I'm meeting a patient on the ward about coming to critical care, the thing I'll often write are things like, when considering the benefits and burdens of further treatment, it's not in their best interest at present to come to critical care, for example. Now, that's quite a complex phrase. I couldn't just invent that top of my brain. It's something I've crafted over years, much like skills you develop of doing procedures or surgery, you should also develop those skills of words and writing. So yeah, think about stock phrases, think about narrative, and think about writing to the patient rather than just about them.
I guess now, not to use the phrase circling back, we were talking a little bit about the kind of jargon we use seeping into our personal lives. And Nikki, you gave like loads of wonderful examples of like query and things like that. I guess it was more for Matt. I was wondering whether you had any experiences of anything similar.
Yeah, so since you've been talking, I'm looking through the messages I've sent on my phone to people over the last few days, and I'm sorry to say that I've done all the things you said. So I've written coffee, query. I've even written as a joke, but it's not particularly funny, close a business. So let me know by COB, although that's a bit more of a business slang, really. I've used I'll revert to you on that. And these are all with good friends arranging to go out for a coffee or a beer. It's not a board meeting. I've even written plan A and plan B. It feels like I'm standing at the edge of a bed in intensive care thinking how to intubate someone and having plan A, B and C. So I suspect, it absolutely infuses into all of our worlds. I think what I'm interested in is those behaviours as well as the words, as you say. So this sounds very sad, but as I was looking on my phone, I saw a checklist. So I've got checklists for life. So when I go on holiday, I've got a checklist of things not to forget. Earphones and phone charger and passport. Again, like I'm standing in work, and maybe I should just chill out a bit and not have a plan A, B and C for coffee, just accept maybe the coffee shop will be shut.
Well, no, I guess you've got the checklist on your phone. A lot of my friends said this, like, have started writing their to-do lists on little pieces of paper, colouring boxes in halfway if they've done part of it and referring it to it as their jobs list. So at least yours has kind of adapted a little bit with you. But that's really interesting because I was really thinking as I was collating this collection whether this was in my own echo chamber a little bit and whether it was just... I asked other resident doctors, people probably at my stage of training, plus or minus 2 years, which plus or minus is another one that we've got on the list there as well. But I really wondered whether it would resonate with kind of more experienced colleagues or whether there would be an entirely different collection of those terms, or if they perhaps would have used different examples to explain the same terms. But yes, it's been really interesting and validating somewhat to hear that Matt's done some of the same ones.
But yeah, I think that's really interesting. It kind of reflects on what we were talking about this whole episode. It's like medicine almost does become a part of your identity. So even if you do want to maintain that work-life balance, the language is seeping both ways. And maybe you kind of get the best of both worlds in that.
It comes back to, I'm sure we've said this on Sharp Scratch before, but everyone thinks they're not a medicy medic. Everyone thinks that they're not that medicy. But I think everyone is more of a medicy medic than they care to admit.
Thank you both for opening my eyes to how much words have power. I thought I knew before, but actually they have power in my personal life as well as in my professional life. So thank you for showing me that.
And thank you so much for your time coming on today and for sharing your wonderful words with us and your experiences. And thank you, Nikki, too. And thank you to the listeners. I hope you enjoyed this episode and were able to learn something too. Make sure to subscribe to the podcast. There'll be a new episode in 2 weeks' time. If you like it, make sure to leave a review and follow us on all our social media, which will be linked in the description. And yeah, until then, I've been your host, Zaynah Khan, and I'll catch you next time. Until then, stay sharp. Bye.